So my name is Quintana. I'm a registered nurse, CDE, which stands for Certified Diabetes Educator. I work for the Diabetes Health Center, which is on this other side of the wall. We teach people how to manage their diabetes. We have two other dietitians, one that's joining us for half a day, who teach nutrition not only for diabetes, but for any other condition. And our dietitians also feel very strongly about good nutrition, and that also helps with mental health. I wasn't sure exactly, it was kind of a broad topic, so I kind of tied it in more with the diabetes. And I think I'll skip over some of the statistics. You've heard some statistics and they're more accurate for our county. These were general statistics. But one of the things I want to talk about is the prevalence of depression and diabetes is twice as much as those that don't have diabetes. Diabetes and depression is also bidirectional, which means having diabetes increases your risk for depression, but having depression and being on medication increases your risk for diabetes. Not only the medication, but the depression and the whole chemical imbalance also increases the risk for depression. It can be a longer course, and there's more incidence of recurrence with having the diabetes. And not just diabetes, chronic illness. People living with chronic illness have a higher risk of depression. It affects the whole chemical imbalance. The depression, so I already said that. Depression, so some of the statistics are that people that have chronic illness have a 3.2% incidence of diabetes. When they have more than one chronic illness, that risk increases. And most of our patients don't just have diabetes, don't just have depression. Usually they have high cholesterol, they have asthma, they have high blood pressure, they have heart disease, they have many other chronic illnesses. So this just adds to their incidence of diabetes. And I'm sorry, I'm probably not following the slides very well. So the next slide, like I said, it's a vicious cycle. It increases the risk and persistence of depression, and depression makes it harder to treat your chronic illness. I have depression up there, but any other chronic illness. I see so many patients that the depression is ignored, and they go to the doctor and they get the finger shaking of they're not following, they're not sticking to their medications. I hate the word compliance. It's used a lot, and patients are always said they're non-compliant. And also, one thing I've seen in all my years of nursing is that the medical field is directed at trying to fix things. We're more at acute. We want to fix a broken leg. We want to cure, give antibiotics for an infection. But when it comes to chronic illness, it's a little harder. And I find that a lot of the times the patients are seen as the one condition, the diabetes, the heart disease, the high blood pressure, and not the whole person as a whole. And depression gets ignored. It's also a little harder to treat. There's a slight higher incidence of diabetes among ethnic groups. Some of the other factors that include is the presence of multiple complications, financial, lower income, lower education, being single, and unfortunately females, we have a higher incidence of depression and mental health. Just one more thing. And it's the same for both type 1 and type 2 diabetes. There's not a difference of that. A lot of times people ask me which is worse, type 1 or type 2, and I tell people that it's not the type really, but what your blood sugars are and how, in general, how your health is. There's also other conditions, not just depression, but it's anxiety disorder, panic disorder, and a lot of these with depression also have some of these that are in conjunction with post-traumatic stress syndrome, eating disorders, and I think eating disorders come along with, as the doctor was saying, that people, when they're on medication, have a tendency to want to eat more, or just the whole process of having depression. A lot of people are stress eaters. When we eat and we go for carbs, we don't go for protein, we go for carbs because it helps our brain release some of the hormones that makes us feel good. And that only lasts a little bit. So people continue to eat. Sometimes they eat out of boredom, but so there's a lot of eating disorders. And there's also something called diabetes distress. There's a research that has been done that also talks about diabetes distress, because when people first get diagnosed with diabetes, they feel very overwhelmed. They feel that they are not able to manage their diabetes. They don't have the support they need. They also have a lot of emotional burden with the diabetes, and financial comes along with it a lot. We have now the Obamacare, the Access Care Act, but there's still a lot of people that don't qualify for a lot of these services because they're not here legally. So the financial burden for diabetes is tremendous. And they already usually have not good access to good foods. They have more access to cheap foods, so that adds to it. I'm sorry, I've kind of lost my place. I'm used to looking at my slides. There is a 2-item screening process to differentiate between a true depression and diabetes distress. The 2 questions, which are very similar to the depression also, if they're feeling overwhelmed by the demands of living with diabetes, and if they're feeling that they're failing their diabetes. They a lot of times feel that they're failing, and that's not common because they're being told they're not compliant, and you haven't done this, you haven't lost the weight, you're not taking your medications, so that kind of adds to it. And so those are the 2 that distinguish. We have the 2 that for depression also that asks, did you lose enjoyment in the things that you normally enjoy doing? So they're, I think, in a sense, they're similar. With the depression, it causes poor adherence to the self-care. I have many patients, I have had a couple lately that say they don't even want to get out of bed. So the last thing they want to do is test their blood sugars. They don't want to see those numbers because they already know that those numbers are not going to be good. And a lot of them tell me that it's like failing a test. So that's where that adds to their failure. So if they're already feeling bad about themselves and they see that those numbers aren't improving, they stop testing. And if they feel that the medications aren't doing anything, they stop taking them. Or they're so depressed that they don't take them to start with. And once they take them, their blood sugars are so out of control that it doesn't make much difference, so why even bother? A lot of the times, doctors are really also quick to scare them. Say you're gonna end up with blindness, kidney disease, but when they're feeling this depressed and they're feeling this bad about themselves, that doesn't really do much to motivate them. I think for a lot of people, that actually adds to that depression. It's like, why even bother? And so it's a very complicated, and this is why I feel really strongly about this, and I feel the depression gets very ignored or not always well treated. A lot of them do have primary cares that do treat their depression, but they give them one antidepressant or just one medication and never really reevaluate to see how well that's doing, or if they need a change, or if they need others, or they stop taking it because of the side effects. They don't like how they feel. So depression increases morbidity. As we've heard before, it increases their lifespan, and it also increases their risk for complications. The diabetes impacts depression, so they impact each other. It's round and round. Diabetes causes an increase in depression because it affects neurovascular changes. There's some genetic influence. If their blood sugars are high, it affects how their brain processes. If their blood sugars are low, it affects how their brain processes everything. So I tell people it's like a car. If you run out of gas, it doesn't start. If you flood your engine, it doesn't start. So the same thing with your brain. If it doesn't have the sugar because it's low, it can't function. If your sugar is high, it can't function because it's not making it into the brain. And it's also irritating things and causing chemical imbalances, so it affects their emotions a lot. And so sometimes I think that's where the confusion also becomes as to whether it's their diabetes that is causing some of the symptoms or the depression. Usually I think it's a combination of the 2. And then, like I said, the depression gets missed. Because of those symptoms, they don't always get diagnosed. Doctors also don't want to ask the questions. We have the 2 simple questions that we have you been feeling down, depressed, or hopeless, or had little interest in doing things? And most of the time they'll answer yes, but I think the doctors are afraid to ask that because they're afraid of those yes answers, and then what do I do? I sometimes get afraid to ask those questions because, as we know, there's not all the resources in the county. We're improving, there's more. If you're in the county system, there's great resources, but if you're not in the county system, then it becomes a little more difficult. I've also found that there's also less Spanish-speaking providers, and the majority of our population is Spanish-speaking, monolingual Spanish-speaking, so that becomes a little harder. We've also in our center tried to look for ways that we can help at least with the stress and some of the symptoms, and we've also looked at mindfulness. We're looking at being able to incorporate some mindfulness into our visits. We're still trying to figure out how to do that. I attended some mindfulness and I really enjoyed it and saw how that helps. So we're trying to see how we could incorporate to some of our services that we provide. I think we have a little more time. We don't have a lot more time, but I think we have a little more time than some doctors do sometimes. And I'm sorry, I'm kind of going round and round. Depression affects how the thought process is. So I'm going to jump to some of the goals because I see we're running out of time. So some of the goals for depression is to schedule a physician. As we said, make sure they have a primary. I also always tell our patients that it's a team effort. It's not just the primary or the psychiatrist. It's a team effort with, as for the diabetes, the educators, the nutrition, the physician, hopefully a counselor, a psychiatrist, somebody that can help them more with their mental health. Exercise, it's been mentioned again, and that's actually one of my last slides. One of the things, the simplest things that I find that helps both the blood sugars and depression is exercise. Studies have shown that 30 minutes 3 times a week can be just as effective as medication. It helps with that chemistry, the brain chemistry to improve, the endorphins, and it helps both with the blood sugars and with the depression. So that's one of the best treatments. But also setting small goals for patients. There's a lot for them to do. When they go get diagnosed or when they go to the doctor, they're given a long list of things they need to do. Check your blood sugars, eat right, exercise, take your medications. What do you do with the blood sugars? A lot of times they're not even told. So they leave the doctor's office already feeling overwhelmed. So we here try to set small goals and meet the patient where they're at. Not as mental health is not a one size fits all. Diabetes isn't either, but the medical field has kind of had a hard time with that. Everybody should test, do their blood sugars, and if they don't want to do these things, again, they're not compliant. So we try to set small goals and meet them where they're at and start with the small goals and what they could do so that we can get them feeling better. And as they're feeling better, then that adds and we're able to do more and improve the whole situation.